Hello, 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 and welcome to another Facebook Live here on your favorite health and wellness channel that is known as blackdoctor.org. I am Ellis Dean, your host moderator for this discussion, and we are excited to have you here with us today. So, this is the month of March, and so what is special about March? Well, we've got St. Patrick's Day. As you can see, I've got my grain on. We've got the start of spring, allegedly, because it's still cold in many places, but it's allegedly the start of spring. We got the start of spring. We've got, and we also have, it's Nutritional Awareness Month, so please focus on your nutrition. Make sure whatever dietary changes you can make, if you didn't keep up with your New Year's resolution, hey, this is the month, March, that we can take care of that. And March is also Multiple Myeloma Awareness Month. Now, most of you may have known those other things, but you might not have known about multiple myeloma and Multiple Myeloma Awareness Month. Well, the good news is we're going to take care of that for you here today. So we've got a riveting discussion as part of our 6-part series on multiple myeloma, and we are working with our friends at Genentech for sponsoring and our partners at Cedars-Sinai for providing such wonderful specialists to talk about multiple myeloma. A couple things I need for you to do before we meet our doctor of the night. Number one is let us know where you're watching from. We'd like to know where people are watching us from all over the world. So please drop your city, state, country. You can put your high school or whatever you want to put in there. Drop that in the comment section and make sure, and we'll give you a shout out if we can. Number two, if you know somebody that needs this information or information that they could benefit from, please tag them or share this on your page. We need to get this out to as many people as possible, and we need your help to get that done. And then number three, if you have any questions throughout what we're going to be discussing today, please also put that in the comment section. And if we do not get it answered today on this broadcast, we will make sure that we'll come back and we will get your questions answered, because this is all about giving you the information that you need in order to have a more robust conversation with your healthcare provider. Finally, as you saw at the top of the program, what we want you to recognize is the information that we're going to be presenting this evening is for informational purposes only. So if you are currently under the care of a physician, please do not make any changes to your treatment plan until you have a discussion with your care provider first, or if you're working with your family or whatever. This is not to take the place of any of your doctor that's seeing you, knows your labs, and been working with you. This is to give you some information to kind of maybe some conversation starters for when you have your next appointment. All right, so now that we've got all the particulars out of the way, I know you didn't sign on to see me, even though you like my smiling face. I'm going to introduce you to our specialist of the day. And this is Dr. David Oveisi. And you have seen him before. He's been on programs with us before. And he's such a special person, specialist. He is passionate about this topic, about multiple myeloma. And we said, who is the best person to close out Multiple Myeloma Awareness Month? And his name is the one that popped up. So I'm going to bring him on and we're going to get our program started. Dr. Oveisi, good to see you again and welcome to this program.
Hi, Ellis. Thank you for having me. Thank you for the introduction, and can't wait to talk about multiple myeloma. I can talk about it all day, but we'll try to keep it to the point today.
Okay, so as a refresher, I know we've done this before, we've done programs before, but you know, I'm a big fan of repetition. Help our audience understand what is multiple myeloma.
Thanks, Ellis. And I think that's an important first question, because the name itself doesn't always make a lot of sense. Even, to other providers, some of the words we use, the jargon for the tests for multiple myeloma, but let's start with the name and what it is. So multiple myeloma is a bone marrow cancer, and it's similar in many aspects to a leukemia. It's a cancer of the blood cells that originates within your bone marrow inside your skeleton. They call it myeloma because it's affecting a different cell than in leukemia, which is the immature cells inside your bone marrow. This cancer involves a type of white blood cell called the plasma cell. And this cell lives exclusively in the bone marrow, and it's supposed to make protective antibodies. That's the normal function of the cell. So when you get sick from a bacteria, a virus, or you get a vaccine, and then you make antibodies, so if you encounter that bug again, you don't get quite as sick the next time. When the cancer involves that cell, you start making antibodies that don't work. And so your immune system is not very functional, and you can get more infections. But that protein can also build up in the blood, the defective antibody, and cause damage to the kidneys, to the bones. And they call it multiple because it tends to involve multiple bones and put patients at risk for fractures. And the word myelo just means bone marrow from ancient Greece. So it's kind of a fancy way of saying a leukemia of a different type of cell.
That was probably one of the best explanations I've heard about it. It just really breaking down even the word itself and multiple symptoms. When you say kidneys, and we all get a little, our antenna go up when we hear kidneys. So how does multiple myeloma potentially impact the kidneys? And can it be confused early on with something like renal failure that is caused by hypertension or diabetes, which are more common disorders that impact our kidneys?
Absolutely. So part of the challenge in diagnosing multiple myeloma and acting on it quickly is because it is a disease of older folks. As you live your life and get exposed to all these bugs and mutations happen in your plasma cells, it tends to be a disease of older people. The average age of onset is 69 or 70 years old. As you can imagine, many of those patients have high blood pressure, diabetes, they may have anemia or iron deficiency. And so when we think about patients we are worried about having multiple myeloma, we use the mnemonic CRAB. And each letter in the word CRAB, C-R-A-B, stands for a different finding in multiple myeloma. The C being high calcium, the R being renal or kidney insufficiency, the A being anemia, and the B for bone lesions or fractures. And you're absolutely right. Patients who have abnormal kidney function, an elevated creatinine, for example, many of them have high blood pressure and diabetes. I think one thing to always look out for if you have kidney insufficiency is if there's a lot of protein in the urine, because that abnormal protein in the urine very well may be from diabetes, but there's a test that can separate just diabetic protein loss from an antibody that's there, and that would be the multiple myeloma. And then, of course, anemia is quite common as well, patients who have bleeding or iron deficiency. But the anemia in multiple myeloma is not explained by an obvious cause. No blood loss, no anemia or B12 deficiency. And so patients like that are the patients that, primary care physicians or other specialists should start to worry about. Could this actually be a bone marrow cancer? And thankfully, we have multiple ways of detecting abnormal protein from myeloma cells from the blood and from the urine before we have to resort to a biopsy of the bone marrow.
All right, y'all. So you just heard about it. It's a different type of protein, but you should be looking for protein in the urine. One of the ways a self-checking, you can correct me if I'm wrong here, Dr. Oveisi, is a self-check for protein in the urine is foamy urine. And so if you have high foam in your urine when you're going to the restroom, if there's a lot of foam, that could be a telltale sign that there is a high amount of protein in the urine. And then that would be a reason to go get checked and be able to determine if it's that protein from multiple myeloma, or it could be something that's determined by diabetes, hypertension, and just high creatinine, and you'll kind of do your staging on your kidneys. So thank you for that distinction. Could you remind us?
One more thing I wanted to add before I forget is that patients with multiple myeloma also may be losing weight like they do in other cancers without, trying to be losing weight without dietary changes, and can also have pain in their bones. And those two, with some of those other findings, can be the big difference. Like, is this just high blood pressure kidney disease, or is something else going on? And so I want to make people aware of those two symptoms as well: bone pain and unexplained weight loss.
So I know most people, especially of a certain age, are not going to be complaining about unexplained weight loss. They're just going to be happy that they're losing weight. So, but you have to kind of recognize if you're not doing anything specifically to lose weight and you start losing weight, that might be a problem. Bone pain, high protein in the urine, and then I've also heard fatigue. Unexplained fatigue is kind of a symptom for multiple myeloma. It's part of that symptom tree for multiple myeloma that can kind of make your red flag go up. potentially, coupled with an age. Now, um, the reason why this show is called Blood Brothers, and I've had some people ask me, why do you call it Blood Brothers? Well, from our perspective, one, multiple myeloma is a blood cancer. The highest at-risk group for contracting multiple myeloma is Black men. And so that's where the brothers come from. And so talk about which the groups, I know we talk about people of African descent, but just talk about who's most at risk for contracting or developing multiple myeloma.
Sure. So it's kind of what we already discussed in terms of age. The older you get, the more likely you are to develop those mutations and genetic mistakes that can give rise to multiple myeloma. But the risk appears to peak in the late 60s and early 70s. For whatever reason, the disease seems to affect slightly more men than women. But I think a much more predictive at-risk group are patients with of African descent, African American, and probably the least impacted demographic are Asian patients. We can still see multiple myeloma in any demographic, so it is important to still recognize that some young folks unfortunately develop multiple myeloma and other ethnicities as well. We know that Black patients who develop myeloma tend to develop it slightly earlier than the national average. And we also kind of pay attention to the genetics in the patients who are diagnosed with multiple myeloma. So it's not thought of as a disease that's passed on through families in the same way as breast cancer, where if you have the mutation, you have a 50-50 chance that you pass it on to your children. The risk of having other relatives affected by multiple myeloma or the precancerous condition that comes before it called MGUS, MGUS, it's more of kind of a slight risk. There's a lot of factors that go into why this problem happens. Most of it just kind of bad luck and mutations. But certainly the environment, certainly the things that we eat, obesity and other inflammatory disorders that can stimulate the immune system may increase the risk. But also having a first-degree relative who has multiple myeloma can increase your risk of having it, can double your risk. But I kind of think of it this way. It's a relatively rare cancer relative to things like breast and prostate. So, it doubles your risk from unlikely to slightly more likely, but it's not the same as, having a 50-50 chance. So I think if you know of relatives who have it, particularly if you're Black or African American, it seems to run through families a little bit more in those patients.
Gotcha. So you mentioned MGUS. Talk about MGUS, because I think that people think that might be something special, but it's my understanding that MGUS is something that's all of us have to at a certain level. Is that true?
It's quite common, I'll put it that way. So MGUS is just a fancy name for abnormal protein. It stands for monoclonal gammopathy of undetermined significance. If you were to test everyone in the country, send all of these protein tests to look for MGUS or monoclonal protein, you would find it in about 1% of the population. Now, a majority of those patients never go on to develop multiple myeloma or another plasma cell cancer, but there's that potential. And so what we do is when we have a patient who may have anemia or kidney disease or some other reason for us to be suspicious, what doctors will do is send a battery of labs to look for abnormal protein. And I'll talk about how each of those tests work in just a little bit, but essentially an MGUS means we have detected protein that's coming from one population of plasma cells that's growing a little bit more than the rest. So you're supposed to have antibodies, but you're supposed to have a lot of different ones. And that should make sense because you should have protection against all these different bugs, not just the flu, not just COVID, against a lot of different things. And so when we send a test called a protein electrophoresis test, we should see a nice smooth mound of different antibodies. We shouldn't see a spike in one particular antibody. If we see a spike, there are ways for us to determine, what kind of antibody is it? Is it expressing heavy chains, light chains, which are different parts of the antibody? And then we can send the light chain tests to make sure that the kappa and the lambda light chains that make up the antibody are equal. And if one is being expressed much more than the other, then that kind of helps us classify the MGUS. And then we can also put a number to it. So it can be very small, 0.1, 0.2 grams per deciliter. And of course, it can be quite high. And anytime we see a high protein value in that M spike, as we call it, M for monoclonal, we start to worry that this is not just MGUS, a precancerous or non-cancerous problem, that it might actually be cancer. And about 1% of patients per year with MGUS go on to develop multiple myeloma. So anytime we find MGUS, those tests should be repeated at least once a year through a hematologist so that we can make sure that it stays low and flat over time and that none of those CRAB features develop, like the bone lesions, the anemia, the kidney disease, that would make us worried that this is transforming into cancer.
Right. So most of us just see our primary care physician, or should be seeing a primary care physician as kind of the gatekeeper to potentially having this. So it sounds like it's kind of more the responsibility for us to say, okay, noticing some body changes, whether it's that weight loss, the high protein, foaming urine, and then the fatigue, and then being able to report that to our primary care physician, and then let them say, okay, let's run these batteries of tests, considering your ethnic origin and your age also as factors. Is okay, because you are a African descent male that's 65 experiencing these symptoms, that it might be best to go run some tests potentially for this particular condition. What are those tests that need to be run to determine if somebody has multiple myeloma or not?
So the first test is called a protein electrophoresis, and it can be done in the blood. We call that a serum protein electrophoresis, or SPEP, which I think is easier to remember, SPEP. And then you can do the same test in the urine. It's called a UPEP, or urine protein electrophoresis. And what they do is they take the blood sample or the urine sample, they run it through a machine that separates all the proteins in the blood and urine by its charge, positive or negative. And normally the antibodies should be kind of a nice, smooth collection. So you shouldn't really see one big blip in the graph after doing this test. And if you see it, then it can be quantified with a number. It'll tell you that you have an M spike of 0.5 or 1 or 2 grams per deciliter. So that's kind of a good test to see if there's any abnormal protein. But it's not perfect. It can be enhanced, meaning we can increase the amount of abnormal protein we find by adding a second test called an immunofixation. And you can also do that in the blood and in the urine. And this test is a little bit different. It just takes the sample and exposes it to a lot of different antibodies that will react depending on which antibody is present that's abnormal. And so this one doesn't give you a number, but it tells you exactly what type of antibody it is. And that's important because that's how we kind of track the abnormal protein over time. Let's say it's producing a heavy chain. There's 3 different types, IgG, IgA, and IgM. It'll tell us which one it is so that we can check that lab in the future. And then it'll tell us the light chain part, the kappa or the lambda. And we have tests for that too. And so that test can be a little bit more precise about what the abnormal protein is. And then the last test that I think is important, because about 15% of multiple myeloma patients don't express any of the heavy chains, and they may not have a really large M spike. They're what we call light chain only myeloma, where their cancer only produces the small fragments that can't be picked up as well by these tests. And so for those patients and for any screen, I like to include the blood free kappa and free lambda test with a ratio, because those 2 proteins in a normal person, kappa and lambda, should be more or less equal. And so if the kappa or the lambda is way out of whack, that can be a sign that there could be something going on in the bone marrow. So the SPEP test, the UPEP test, the immunofixation in both the blood and the urine, and the serum kappa lambda light chain test. Those together, I think, is a pretty good screening test to see, do we need to worry about multiple myeloma? Now, there is a very rare entity. I just want to bring it up because it can exist where someone can have multiple myeloma, but they don't make any of that protein. It's called non-secretory myeloma. That can be very hard to diagnose if there's no protein in the blood or urine that's of concern. But if you develop anemia and kidney failure and fatigue and weight loss and all of the hallmarks of multiple myeloma, I think it still would require referral to a hematologist, and the only way to figure it out is by doing a scan of the bones and a bone marrow biopsy.
Okay.
But for almost all patients with myeloma, these blood and urine tests are pretty helpful.
Now, I've also been told that that bone pain can also be the bones can become brittle and break more easily as a result, because that protein, it's like almost like Pac-Man. It tends to feed, or like a virus, it tends to feed on the bones and makes them a little bit more brittle. So that could also be potentially a symptom if you're having unusual breaks that would normally be kind of a normal fall. Hey, if you're an adult, you fall, okay, there's a bruise, but if you're breaking things, that might be a sign as well. Is that true?
That's true, and we call the fracture of a bone with kind of less than usual force a pathologic fracture. So a common story that I hear from patients, even if they're older and prone to osteoporosis like older women are, if you have a fracture from just carrying in your groceries, an arm fracture, for example, that is not normal. We've had patients who have had gotten in a car accident and fracture a vertebra, when it wasn't a particularly high speed accident. That can sometimes not be normal. Or patients even who've undergone trauma. I had a patient who was young and fell off his motorcycle. And incidentally, not only did he have a fracture in his spine from the trauma, but he had a bunch of old fractures that weren't really explained by his injury. And so anytime we see either early onset of osteoporosis or weak bones, or fractures that don't quite make sense, it would be a very reasonable thing to do to send all of those blood tests for multiple myeloma.
Gotcha. Okay, so now a patient's been diagnosed with multiple myeloma. You run the test, it's come back positive. How does that treatment course run?
Sure. So I think everyone who has abnormal protein, when it's high enough and the hematologist is concerned, a bone marrow biopsy has to be done to essentially confirm that there's enough plasma cells inside the bone marrow to reach that diagnosis. One thing I haven't brought up yet is that there is an in-between diagnosis between MGUS, which doesn't cause any problems, and multiple myeloma, which should be treated. That in-between diagnosis is something called smoldering multiple myeloma. And most patients with smoldering multiple myeloma don't necessarily need to be treated yet, but should be seen by a specialist and should have those labs checked more often, because they are at higher risk to progress to cancer than patients with just MGUS. And that has to do with how many plasma cells are found inside the bone marrow. But provided that you meet the diagnosis for multiple myeloma, we generally recommend starting treatment as soon as possible, because we know that without treatment, these cells grow, eat into bone, and that protein in the blood and the urine can clog up the kidneys and cause kidney failure, fractures. And we want to avoid those organ damage events that really significantly affect patients and reduce their quality of life, and also, reduce their survival. Once you have kidney failure, we know patients don't live as long as patients who don't have kidney failure. So our goal is really to kill the cells as quickly as possible, reduce the bad protein as quickly as possible, so that the damage can be reversed and avoided. And we're starting to use kind of more of our advanced treatments nowadays. In the past, the first question we would ask is this patient young and healthy enough to undergo a stem cell transplant? And if the answer to that is yes, then we would treat them in the past with a combination of 3 drugs followed by a stem cell transplant. Now, I think more and more we are starting to use a 4th drug called daratumumab or isatuximab. They're of the same family. It's an antibody cocktail that we've added to the 3 drugs with not much added side effects, but certainly an improvement in how long patients are in remission after the treatment starts. So I guess to just simplify it, once someone has multiple myeloma, we should ask ourselves, are they healthy enough to undergo a stem cell transplant? And if so, they should be treated with 3. And now I'm routinely giving patients 4 drugs to get them into the best remission as possible before a stem cell transplant.
Okay, that's really good to know. I guess the next step would be, okay, so they're how healthy are they? Will help you make that determination. Can they handle the stem cell? And then that is your decision tree that says, okay, if they are, then we'll follow this course of path. If they aren't, we'll follow this course of treatment. How long are each one of those paths in terms of treatment? And then what will they require specific caregiving needs? Will they need to have a partner that can help them? Because I understand that chemo, it can be really damaging to the body and to the system. So one is that how long are the course of these treatments, and then two, what type of caregiving will the patient need?
That's a really good question. And I think that's one that we struggle with, because either decision branch point, if you're going towards a transplant, we know that patients are going to need support in the post-transplant period when they're still feeling pretty sick from the procedure. And even if they don't get a transplant, that means that they're too old and frail to do a transplant safely. And those patients still need a lot of family support and caregiving support. So no matter how you slice it, I think patients will need support in the form of caregiving with friends and family. It's just when patients are healthy enough to do a stem cell transplant, usually the support is more short term after the transplant, and then they kind of go back to their normal level of function. And in many ways, they feel better than when they were first diagnosed, because they will have been in remission. But to answer the how long question, this is a difficult one for multiple myeloma. I haven't brought up kind of how long patients live with this disease yet, but it is thought to still be an incurable cancer, and we are fighting every day to try to find what the special cocktail is to get patients into a forever remission or a cure. But until that happens, we know that patients who are going to have a stem cell transplant should have 4 to 6 cycles or rounds of treatment, of chemotherapy. And each round is between 3 and 4 weeks, depending on the cocktail you use. So I tell most patients, prepare to be on treatment between 4 to 6 months before the transplant. And I also use the word chemotherapy a little bit loosely here. Thankfully, in multiple myeloma, most of the drugs we use are targeted towards plasma cells and are not actually chemo drugs in the old school sense of the word, where it kills all rapidly dividing cells and makes you lose your hair and throw up and have diarrhea. They all have different side effects. So not to say that you won't have side effects, but the side effects are different. And it's not, many patients are on treatment and don't visibly look like a cancer patient, which I think is a good thing for some patients, but others can feel really isolated by that. They kind of suffer in silence with this disease, and no one else knows what's going on unless they share it with them. So I think having a caregiver is really important, not just for the physical support. After a transplant, we tell patients for about a month, expect to require 24/7 caregiving to make sure that they recover. And then for about 3 months, they may need someone just on standby if they're not feeling well. But besides physical support, I think emotional support is very important as well. Patients were polled with multiple myeloma, and one of the main symptoms of myeloma patients was worrying, which was kind of unique to multiple myeloma. And I think it has to do with the fact that myeloma almost always eventually comes back, and a lot of patients are worried about that. And a lot of the treatments can cause side effects, some of them permanent if you don't recognize it. And I think patients are kind of in a state of worry at all times. And our goal is really to reduce that worry by extending the amount of time they're in remission and by surrounding people around them who can help them through that tough time.
That is fascinating, and I appreciate that, because that worry. I've asked that question before in terms of what type of mental health care is required, because when you hear as a patient, when you hear cancer, any type of cancer, there's going to be some apprehension that comes along with that. And then when you say something is incurable, then that probably is going to take it up a notch, versus like breast cancer or prostate cancer that has higher forms of survival and curability, where people can go in full remission and not have anything happen before again. So that's good to know. Now, you mentioned side effects. What are some of those side effects? And are they? And you said permanent. So what are some of those side effects, and what are some ones that patients need to be more concerned about?
Sure. So I'll talk about the 4 drugs that I usually use before a stem cell transplant. And then I'll talk a little bit about some of the drugs we use for older patients. So the first drug and the newest one that we've added to frontline therapy, meaning the first treatment we ever give for multiple myeloma in the beginning, is a drug called daratumumab or Darzalex. It's a monoclonal antibody against a protein on the myeloma cell so that your immune system can get rid of the myeloma cell without causing damage to the rest of your body. And you can imagine that this is pretty targeted towards those bad cells. So the side effects are going to be less than some of the other drugs that we use. Darzalex now comes in a shot form, a shot under the skin. And with some pre-medication, it's really made the shot a lot easier to give. The main side effect of this drug is a kind of an allergic reaction. So anytime you receive a new antibody cocktail, your body can react to it with kind of fever, a rash, difficulty breathing, and it can be serious. And we were seeing a lot more of those reactions with the IV form. And for that reason, we used to have to give the IV for many hours or split it over 2 days for the first dose. But we have a protocol at Cedars where we give a lot of pre-medication, Tylenol, Benadryl, and other medicines that reduce the risk of that reaction. And then after the second and third dose, the risk goes down even lower. And after the third dose, if there was no reaction, we don't give any more pre-medication, and it becomes about a 5 to 10 minute shot, which is a lot more convenient for patients. Now, that drug can't tell the good plasma cells from the bad ones. So by eliminating plasma cells, patients can have a higher risk of getting an upper respiratory infection or an pneumonia. But those are kind of the main side effects of the drug, that you can have an early reaction, but that it's less common with the shot. And then you can have a higher risk of upper respiratory infection. But patients with myeloma are already at risk for infections. So we don't see it as like a huge additional risk. Now, the other drugs, Revlimid being the pill or lenalidomide, Velcade or bortezomib being a shot, and dexamethasone, which is just a steroid similar to prednisone, they're all a little bit different, and none of them are kind of old school chemotherapy drugs. But the Revlimid causes a rash, some diarrhea, a little bit of brain fogginess, and can affect the blood counts. So we always keep an eye on those with blood work. And it can also increase the risk of blood clots. We know patients with multiple myeloma are at high risk during the first 6 months of their treatment. And so we put everyone on a minimum of a baby aspirin to prevent blood clots. Now, the Velcade shot, this one can cause diarrhea or constipation by affecting the nervous system in the gut. And the main side effect we worry about is neuropathy, peripheral neuropathy, which is damage to your nerves. And so the side effect we ask patients to look out for is numbness or tingling in their hands or feet, or a burning pain, temperature sensitivity, or a shooting pain. It's important to recognize the side effects and to tell the doctor, because we would pause the medicine, wait for it to get better, and then we may even change the dose. Instead of once a week, change it to every other week. And it's important to be aware of, because if we don't know about it, some patients, they are worried that if they stop the drug, the myeloma will get worse, so they keep the side effect to themselves. The problem with that is that the side effect can become permanent and cause chronic pain. So we're really quite aware of that side effect. And the longer you're on the drug, the higher the risk is. And then the last one is dexamethasone, which is an oral steroid given once a week. Thankfully, the way it's given once a week, you don't see some of the same steroid side effects as those who have to take high doses for other conditions like lupus or autoimmune disease. The steroid does kill the myeloma cell, and it also helps the other drugs work better without side effects or reactions. The main thing for patients to know is that if they take it late enough in the day, it can cause some insomnia on the day of treatment, so they have trouble sleeping. It can also give you a little boost to energy for a couple days, and then a few days later, a big energy crash until their next dose. I think of steroid as like adrenaline in a pill. So you kind of give a big boost of adrenaline, and then that kind of runs out, and you have an energy crash the next 2 days later. So sometimes when patients have that side effect, I'll split up the dose and have them take it, a half dose on one day and a half dose a few days later, and that makes it a little bit more tolerable.
Okay, wow, that was very thorough, and thank you for that. That was impressive. That that you knew all of that, and you're speaking with your patients about how to counteract that. Neuropathy, I'm assuming that's the one you were talking about that could hang around longer than in any of those other symptoms. And you have to be very, very cognizant of that, because neuropathy is part of many conditions, including diabetes. So when we're talking to a population here on blackdoctor.org, diabetes is disproportionately impacting people of African descent here in America. And so neuropathy is a term that is probably pretty familiar amongst the people that are watching this programming. So caregiving, I love the fact that you talked about worrying and looking at treating the whole patient, because a lot of times when we're, some of the reasons and some of the distrust or mistrust that can happen is, the patient can start feeling that, hey, the doctor is not concerned about them, they're concerned about the disease, right? Oh, we want to treat the disease and not the person. And it's important to hear someone in your position say, hey, we're going to make sure that we're treating the whole person as well as their emotional state, because one, that's going to create more trust between patient and provider, and two, having that worry state go down goes a long way towards their outlook towards treatment and towards living with multiple myeloma, even though it isn't incurable. Because as you many people have lived several years, 10 plus years with myeloma, just on a maintenance regimen. And so it's not a so quote unquote death sentence as when we hear cancer, when we hear incurable cancer. It's just a matter of how long does it stay in remission within the body. So I'm going to get off my soapbox because you're the expert here, not me. So with families, I think, speaking about caregiving, a lot of times, when families hear that family member is in crisis or has been diagnosed with the illness, such as multiple myeloma, that can change the dynamic, particularly when we're talking about an older family member that might be considered a leader in their community, a leader in their family, a leader in their church. How can families better prepare and better step in to be able to caregive if they're so concerned, about their own needs from this particular person that's being treated for multiple myeloma?
Yeah, that's a great question. And I think it's a difficult one to answer because everyone is in a different place in their life when they're diagnosed with multiple myeloma. And patients have kind of different levels of support. So I think in patients who are previously very independent, previously, the patriarch or matriarch of the family, leaders in their community, it can be a very difficult transition to being the sick one, to being the one who needs the help. Right. And so what I tell patients is that you don't have to be alone in kind of this transition, and that it's not just your responsibility to kind of find that help. We rely heavily on our colleagues in social work when someone's diagnosed with multiple myeloma, and also the supportive care medicine team. At least here at Cedars, at other places we call it palliative care, which I think has kind of a negative connotation because I think some people associate palliative care with only hospice and end of life and kind of giving up and not doing treatment. And that's not the case. Here we call it supportive care to try to highlight that that's really their goal, is to support the patients through their diagnosis. Yes, sometimes at the very end stages of the cancer, it means talking about end of life care and transitioning to more focus on comfort rather than chemotherapy. But we have a great supportive care medicine group here that can be involved early on if there are special needs. If the patient was responsible for putting food on the table, and if they need help with applying for disability, we very routinely will write letters of support for family leave, for especially for relatives who are going to be the caregivers during a transplant, to make sure that everyone has that chance to get their loved one back on their feet. And I think sometimes we can accomplish all of this with just the oncologist, the social worker, but sometimes having a dedicated care team called supportive care or palliative care, whatever it's called, at your hospital, can be really helpful because they have a little bit more time in the visit to focus on those important things, whereas the oncologist is also dealing with the chemotherapy and the treatment. So it's important to just make sure that someone is acknowledging that part of the treatment. And I encourage patients to bring their caregivers to our visits. Whatever the COVID restrictions are, we allow up to 2 family members in the room at any given time, but we telephone conference all the time, whoever is important to be, part of the discussion. Sometimes it's a very large conference call, but we make it work.
Well, that sounds like, that could be a bit overwhelming from a provider standpoint, but from a patient standpoint, that could be very comforting to know that many people care about their care and about their treatment. And so they want to make sure that they're informed. So therefore, their village around them can help them through this process. And so I do think that when we're talking about something, whether it's any illness, but when we're talking about something as serious as multiple myeloma, I think it's one, you bring up a good point, even though you didn't say it directly, but one, that means sharing with others. You get that diagnosis, you might get that diagnosis individually, but if you have a spouse, if you've got children, if you've got a community, even if you don't have a spouse or children or partner, you've got a community of people, the more that you can share that, the better chance you have of really having them be that strength sometimes when you need it. So number one, sharing with that. Number two is that having them there with you so they can hear. Because sometimes when you hear that word cancer, your mind can melt a little bit for that moment. And there was a great scene. I was watching a movie the other day. There was this great scene, and it was a person and his caregiver, his partner, and they did a good job of depicting his mind going blank, and they just had it was like a space, and the partner was talking to the doctor, but you couldn't hear anything, but it was coming from the perspective of the person with cancer. And that's really a lot of times what it's like sometimes when they're just like, okay, what's going on? And then they catch up eventually after a while. So really stepping in, I think caregiving is really not talked about as much as it's being talked about more as we move forward. And I'd like to have that be a bigger part of what we talk about here on Black Doctor, because the disease is not in isolation. It is something that impacts the entire community. So we have to treat it.
And Ellis, you brought up mental health. I want to not neglect that as well. I think there's a push everywhere, cancer or not, to address mental health and make patients realize that they shouldn't be afraid to seek help. And I have lots of patients who, after their diagnosis, they sought a therapist, either on their own, through their primary care doctor, or through the cancer center. We have cancer center psychologists for therapy, and also psychiatrists if they feel like they're, not coping well to the point where they think they might benefit from a medication. Or maybe they already have anxiety or depression, and now they need to reframe their cancer in the context of having anxiety and depression. These are very common things for patients to go through, and I want to try to normalize that. And some patients may not feel as comfortable sharing everything with their loved ones, and that's okay too. We always encourage them to have an open dialogue so that there's extra care and support within their family, but some find it very helpful to talk to others who have gone through the same thing through support groups. We have a lot of support groups in, LA is a big metropolitan area, but I'm sure other places also have support groups through the Multiple Myeloma Foundation, through the Leukemia and Lymphoma Society. I gave a talk at a patient conference just last weekend in Orange County, which was exclusively for patients and their family members, to hear from experts in the field of different blood cancers so that they can get some information about multiple myeloma, but in a way that they could understand, but still coming from an expert. So all of these ways of getting extra support, getting extra information, I very much encourage patients to seek. And, I think a lot of patients are hesitant at first, but certainly if they're apprehensive about treatment or about a stem cell transplant, I try to connect them with one of my patients who's gone through something similar, and ideally who comes from their same background. Who is also of African descent, who's also active in their church. And I think it helps just kind of hear that, they're not alone, and that there are other people like them who've gone through the same thing.
I did hear from another interview that African Americans are less likely to get stem cell transplants. Is that true? And then have you gotten any, whether it's real hard data or just kind of anecdotal data as to why that is? Why are we less likely to get the stem cell transplant?
No, that is unfortunately true. It's true of stem cell transplant and also CAR T cell therapy, which is a newer cellular therapy that we give to patients who have more advanced disease. And the reason for that, I think, is not just one reason, it's a multitude of reasons. Unfortunately, I think it's similar to the reason why Black patients take longer to get diagnosed with multiple myeloma. It's the same reason that their outcomes and survival is not as good as other groups. However, when you control for factors that are not medical, meaning if you control for access to care or not having access to care, when you control for insurance differences or lack of insurance, and you kind of put everything on an even keel and say, okay, the time to diagnosis would be the same, the treatment would be equal. And we know that Black patients get offered less treatment than other racial groups for one reason or another. But if everything is equal, the outcome in Black patients is just as good and sometimes even better than other groups. And part of the reason for that is we think that Black patients have a slightly lower rate of having high-risk genetic mutations, not ones that they inherited from their parents, but ones that the cancer cells develop over time that can predict a bad outcome. So the genetics of Black patients who get myeloma may be a little bit more favorable. The key really is early detection, early treatment, using stem cell transplant if they qualify, and then using CAR T later on if they're fit for it. But we have to do, I think, a better job of taking folks seriously when they come in with pain. And that's a problem across all diseases, not just cancer. We know that Black patients who have chest pain are less likely to get an EKG or will get an EKG later. And so we really have to do a better job of believing patients when they come in with pain and not discounting that, oh, it's just their diabetes causing the kidney disease, or it's just, they are pain seeking. We are trying to dispel those myths in sickle cell disease all the time. And many of those biases still exist in multiple myeloma. But the other problem is access to care. And I think for a lot of different reasons, we just don't have as robust of a healthcare system for all comers as other countries that have public healthcare, and that's why outcomes in certain diseases that affect minorities, the outcomes are much worse in America. So I think we have to do a better job advocating for patients to connect them with social work to help them enroll in state insurance if they qualify, or to help them navigate the insurance system to pick a plan that's going to allow them to get standard of care. And that part is really challenging because doctors are bad at insurance. We are not good at knowing all of the rules and the loopholes, and we have to lean on
We're bad at
other
it too.
people. Yeah.
I think only people understand insurance. I think only insurance people understand insurance. It's just like, did I sign up? Am I good? What's my copay? That's all I want to know. And am I covered? That's it. And the rest of that, it gets out of control. But you're making some very good points. And there's two words that popped into my head when you were talking about that is health equity. What you're describing is health equity. If everything is equal, this is the outcome. And so there's all those factors that make it unequal that are impacting outcomes outside of the patient's genetic makeup. And so what we're trying to do as hospitals, as providers, as organizations like Black Doctor and others, what we're trying to do is just say, hey, look, let's control or try to eliminate or reduce as much of those other factors as possible so the patient has the best possible chance to have the healthiest outcome for them. Now, they may still not have a positive outcome, but if we can remove all that noise, that outcome is determined upon themselves and their body and not some other factor that's out of their control. I just read an article today that was talking about it was a social media influencer, but she recently passed away from cervical cancer. And
I read that too.
Reading the article, she kept getting sent away with saying, oh, that's just fibroids, because she had heavy bleeding from her vaginal area. It wasn't until she got diagnosed later, almost a year after she started experiencing the bleed, that she got diagnosed with cervical cancer. And that's a tragedy, but we need to take those stories and use them as kind of that building block and say, okay, we've got to do a better job of recognizing, at risk, or just at least running the tests that says, hey, is this something else besides just your traditional fibroids? So,
Right.
that's a big.
And one more thing I want to add from the medical side that sometimes prevents patients from getting transplants is that, other medical conditions that affect Black patients, high blood pressure, diabetes, kidney disease, heart disease, liver disease, sometimes patients are very sick from other causes when they're diagnosed with multiple myeloma. So my advice for things that can be modified is that if you have other conditions like that, to make sure that your doctors are having those conditions controlled on good medications, that patients are taking the medications so that once they are diagnosed with cancer, we're not forgetting about the other diseases that, if we neglect the heart failure or the liver disease or the other issues, those can pop up and prevent someone from getting a safe transplant. So I think making sure that the whole person is treated and that we don't forget about the other medical issues. I always tell my patients that, I'm not supposed to be a primary care doctor, but I will do my best to address the other medical issues if they don't have one, because they are extremely important that we control them and don't forget about them just because they have cancer, because myeloma is kind of the long game. Patients on average are living 8 to 10 years now. It's becoming a chronic illness, just like diabetes and high blood pressure, something that you can control with medicines, but that's just it. You got to make sure you control it, and that, patients are aware that it's really important to take the medicine.
Couldn't say it better myself. So as you've been watching with us, we've got Dr. David Oveisi from Cedars-Sinai, our partners at Cedars-Sinai, and we're talking about multiple myeloma, and we're talking about it from a caregiving standpoint. So we broke down early in the show what is multiple myeloma, kind of gave you a refresher in the beginning part of the show, talked about the treatments, some side effects, and then we also talked about what does it mean to be a caregiver or to accept caregiving as a multiple myeloma patient. So couple of things that one, some takeaways, some key takeaways for you as we're wrapping up here, as we're coming towards the end of our hour. Number one, be as healthy as possible, because Dr. Oveisi didn't say that he didn't say that explicitly, but I'm saying that is because that can prevent you from being able to participate in some of the treatments effectively that come with multiple myeloma, having hypertension, diabetes, all of these other conditions that could prevent some of the treatments. So be as healthy as possible before anything can happen. Number two, have somebody to talk to, and whether that's a family member or whether that is a trained professional counselor, have someone that can help you carry that burden, that mental burden that can come with potentially living with multiple myeloma. Being able to express yourself, being able to express your frustrations, your fears, all of those things go a long way to lifting that burden off and can have better outcomes for you both mentally and physically. So have a person. Number three, find your doctor like Dr. Oveisi, right? That's going to be thoroughly knowledgeable, but it's also going to say, okay, we're going to treat the whole person and not, yes, he is focused on, as a hematologist, as an oncologist, he's focused on treating cancer, but he's going to give you resources, he's going to provide resources and people available to you that you need to take advantage of. You can't put it all on the doctor. He's got other responsibilities. Let's lean into that village that they have prepared for you so you can get that overall palliative care that we talked about on this program. And finally, again, it is not, even though it is technically still an incurable cancer, people can live very long lives, productive lives after being diagnosed with multiple myeloma. I know of one personally that lives still alive, living over 10 plus years with multiple myeloma. And so we do have to recognize that if we lean in, we go through all of the treatment plans, we can get back to a place where that is in remission. Is that what it would go into, Doc? Is that remission? We would get into remission and try to stay there as long as possible so it won't come back. Finally, Doc, at what point, and this is kind of the morbid side, but at what point do you start having a conversation about hospice care?
So what I try to tell all my patients when I first meet them, whether it's at the beginning of their myeloma journey, somewhere in the middle, if I've been referred by their local community doctor, community oncologist, or if it's towards the end and we're running out of options and their community oncologist is asking for help, is that, you know, we're going to treat this as best we can and try to get this into remission. And most of our drugs work quite well. But over time, the drugs get less and less effective. And every time multiple myeloma comes back or relapses, the time that patients are in remission from the treatment gets shorter and shorter. So there may come a time in your journey where I tell you that, you know, we have exhausted all of the reasonable therapies, or their bodies have become too sick for us to do treatment that's safe, and that doing more treatment at this point may cause more harm than good. And instead, we kind of shift our focus instead on the quantity of life and start focusing on the quality. And I think for older folks with myeloma in particular, we should be thinking about quality of life from the very beginning. We shouldn't be doing aggressive treatment that's going to make old people sick. We should be doing treatment that's going to be tolerable but also effective. But even despite our best efforts, if side effects occur, if complications arise with their organs, if they become so weak that they can't do their daily activities or they can barely get out of bed in the morning, or if we've exhausted all of the good drugs we have, which are many. There's more than 15 FDA-approved drugs for multiple myeloma, but if patients live long enough, they will exhaust all of those reasonable medicines. And at that point, your oncologist, a good oncologist, should tell you, hey, remember that conversation we had way back when I met you, that I would be honest with you and I would tell you if I thought treatment would hurt you more than it would help you. We're reaching that time now, and I think it's important to talk about ways to make you comfortable and honor what's important to you. And many patients would rather be at home surrounded by family than to pass away in a hospital. And we do our best to honor that wish when it gets to that point. And I'm a firm believer that patients going home with home hospice care have a far better end of life experience, not just for them, but for their families, than patients who are, you know, aggressive until the bitter end and die with a tube in their throat in the ICU. I think most patients understand once it gets to that point that we're trying not to harm them. And sometimes the best thing we can do is by doing less and not doing things that are going to hurt them. And so thankfully in multiple myeloma, we are not having that conversation for a while, but some patients, you know, despite our best efforts, they don't live to that average of 8 to 10 years. Not all myeloma is the same. Some myeloma with the high risk mutations can be very hard to treat and their survival is not as great. We're trying to change that. But if it gets to that point, I think it's good to listen to your doctor. We always encourage second opinions and talking to another expert and making sure they agree. I would also say if you're still in reasonable shape, but we've used all the drugs that we know how to give, clinical trials are important in multiple myeloma because there are many drugs that are not yet FDA approved that we're studying. And I think there's a lot of hesitation around clinical trials because of the history of taking advantage of minority patients in those studies back in the 40s and 50s. What I would say, though, is that there's a lot more regulation now, and most of the myeloma trials are comparing what we know works, so 2 or 3 drugs that are approved, and adding another one so that hopefully the outcome's even better. So it's not that we're, you know, withholding treatment from them. We're just kind of, most of the trials are adding to what's already effective. And the benefit is that you can get a treatment that might not be approved for several years where, you know, it may be too late at that point. So talk to your doctor about clinical trials, what's available. But if you're not in good shape, if you can't even get out of bed, then unfortunately, not even a clinical trial is likely to work at that point. And, you know, start thinking about where you'd like to spend the last days and weeks of your life. And most people would prefer to be comfortable.
Absolutely. Well, you know, I hate to end on that note, but that is something that we have to talk about because it's part of anything that we do when we're talking about illnesses such as this. And so thank you, Dr. Oveisi, for your time. Thank you all for joining us. We want to thank our partners at Genentech and particularly our friends at Cedar Sinai for giving us. I know how much his time is worth, and so for him to give us an hour, we're very, very grateful for that. And so I want to thank you all for joining us. Please leave your questions, your comments, everything in the comment section, and we'll see you next time on blackdoctor.org.
Thank you for having me